Hello, and thank you for joining today's webinar on fetal cardiac imaging from basic to advanced. My name is Kathy Elliott, and I am the Marketing Director for GE Healthcare Women's Health Ultrasound, and I will be your moderator for this evening's webinar. And now I'm honored to introduce our esteemed presenter for this evening, Dr. Elena Sinkovskaya. Dr. Sinkovskaya is a professor of OBGYN, Director of Ultrasound Research and Education, and Program Director of the Fetal Cardiology Fellowship at Eastern Virginia Medical School. She will discuss current fetal cardiac imaging guidelines and how incorporating new ultrasound technologies can aid in the detection and diagnosis of fetal cardiac anomalies. Welcome, Dr. Sinkovskaya. The floor is yours.
Thank you, Kathy, for this kind introduction. It's my pleasure and privilege to share my experience in the field of the fetal cardiac imaging with you today and present to you the latest and greatest technology of GE Healthcare for the prenatal imaging of the fetal heart. We are going to discuss current guidelines and sonographic techniques for fetal cardiac evaluation. We will see how we can incorporate new sonographic modalities into fetal cardiac assessment and apply a systematic approach for the prenatal diagnosis of the cardiac anomalies. As you all know, the demographics of the congenital heart disease presented here, it's the most common congenital malformations affecting about 8 to 9 per 1,000 live birth, and that percentage is even higher than we evaluate fetuses. In average, if we do some approximation, we know that about 1 million people currently alive in the United States affected by congenital heart anomalies. And if we look at the numbers, so just imagine that about 3 patients with congenital heart anomalies are born per hour. So every 15, 20 minutes, we have the new baby affected by the heart disease. So looking at the approach of the cardiac imaging, I would like to highlight that can be done in 2 different settings. One, and I think that we are going to concentrate the most on this modality, this is the screening examination. Without appropriate screening, those fetuses will never be able to reach the specialists in fetal echocardiography and have the accurate diagnosis before birth. So the screening examination, as it follows from its definition, performed on everybody. We are looking at the direct and indirect markers. And people who are performing this exam, they have a basic training in ultrasound. And usually this is exam that is performed within the settings of the general OB, even though some MFM practices do this as well. So we usually target gestational age between 18 and 20 weeks. This is the typical gestational age for our second trimester screening exam, not just the heart, but the entire anatomy evaluation. And we rely on the 2D mode in terms of the ultrasound modalities used. And I will show you that some guidelines suggesting the help of the Doppler is really important for screening. So if something was detected or suspected during the screening exam, if we have the patient who is screened positive, that means that this patient not necessarily has the congenital heart anomaly on the fetus, but that means that she will benefit from the detailed assessment, which is the fetal echocardiogram. So this is an exam that performed by indications. We usually assess the multiple planes during that exam using different modalities. Everything that you can imagine, 2D, Doppler, a stick acquisition, or any type of volume imaging, assessment of the cardiac function, all of that could be a part of the fetal echocardiogram. No wonder that that exam requires the training and expertise that is available usually in the pediatric cardiology settings or MFM. And traditionally, we perform those exams between the 20 to 22 weeks. This is the optimal time, but indeed, at any time during the pregnancy, from 12 weeks to 40 weeks gestation, if the cardiac anomaly is suspected, we should perform the fetal echocardiogram. So, but let's start from screening. if you look at this picture, so I think that resembles what we have to deal with. Then we are looking in the low risk obese settings. So if I ask you, can you find the 3 ladybugs and the 3 baby smiley faces within these coffee beans? If you don't have the strategy to look for them, so probably it's going to take a very, very long time and you're not going to be successful. So that the cardiac anomaly screening also a very challenging task. And I think that it's very important to have your strategy to be successful doing this. So what other strategy historically applied for the screening for congenital heart disease? We relied on the risk factors for congenital cardiac disease that pretty much pre-existing the pregnancy. This is the family history of congenital heart anomalies on the previous babies or on one of the parents or in the family in general. This is metabolic diseases of the mother, such as the diabetes or phenylketonuria, teratogen exposure, IVF pregnancy. But unfortunately, this strategy is not very successful because only 10% of the babies that show some risk factors who are affected by the cardiac anomalies. So that really the right thing to do is to perform the routine screening on all pregnancy, and this is really important and necessary. So how well do we do in the prenatal detection of the heart disease? Unfortunately, if you look at the statistics, despite of all the advances in our technical component, our machines are getting better. So prenatal detection of the cardiac anomalies fails in approximately half of cases for the major congenital heart disease. And based on the screening programs in the most developed countries, the detection vary between 30 and 60%, and that highly dependent on the type of the cardiac defect. Most commonly, anomalies which are missed, this is the conotruncal lesions, such as the tetralogy of Fallot. And this is because this is an anomaly that usually presents the normal appearance of the four-chamber view. And inclusion of the outflow tracts and the free vessel and trachea view indeed helped us to increase the detection rate of the cardiac disease. So here is a great example from our practice that illustrates how life can be and how the cardiac anomalies can be missed. So this is a few years back. This patient was referred pretty late in the third trimester. She was late for prenatal care, no insurance, multiple comorbidities of the pregnancy, maternal obesity with the BMI of 58, and a dichorionic diamniotic twin gestation. And you can see that this is the sweep through the heart and the chest of the baby on twin B. And if you look very carefully here, we will be able to identify that cardiac anomaly. You can see that the vessel that originates anteriorly, this is indeed the aorta, and the vessel that originates from the left pumping chamber, this is the pulmonary artery because it has the bifurcation right here. And this is a classic presentation of the transposition of the great arteries, but it was not detected prenatally. And I would like to highlight this great paper from Netherlands that looks into the reasons of this failure of the cardiac screening. And as you can see, there are 3 main reasons. One is the lack of the adaptation skills. So in other words, that the images were obtained and saved not that required by the screening guidelines. The other problem, this is our case, then the images were obtained and they adequately shows what needs to be shown, but it was the failure to recognize the anatomy that was very well visualized. In other words, it's a reading error. And then obtaining the adequate views, but the anatomy was not visible. So this is, of course, the case. Then the visualization is very, very limited. So, and as you can see here, the sonographer image acquisition errors are responsible for half of undetected cases. So if you have a good strategy, so you will be easy, that the task of this brain teaser can be resolved really easily. So the factors that really affect the visualization and the detection rate is the maternal obesity, And you can see here the image in the first trimester that the increased distance from the probe to the area of interest, the fetus and the fetal chest, is really makes the imaging very challenging. Also, I would like to attract your attention that the detection rate is highly related to the socioeconomical factors, and it was increasing evidence in the literature that the detection of the major cardiac disease, such as the transposition and the hypoplastic left heart syndrome, really significantly decreased based on these factors. So this is really important to have in your community the good access to care for all categories of patients. So that all this said and highlighting the problem, so how can we improve the situation? First of all, it's very important to follow the guidelines and practice parameters. So I'm happy to announce that this year, the AIM, American Institute of Ultrasound and Medicine, published the revised guidelines for the screening, and it's presented here. And here we have the assessment of the heart that should include the four-chamber view. Also, we need to look at the cardiac size, position, and situs, left ventricle outflow tract, right ventricle outflow tract, and three vessel and trachea view. Then it's visible. So also would like to highlight that for patients of the high risk, such as the maternal diabetes, advanced maternal age, and a long list of indications so that the patient may have, we also have the detailed second or third trimester diagnostic ultrasound. And here on top of those parameters and views that were highlighted on the previous slide, we need to take a look at the aortic arch, superior and inferior vena cava, ductal arch. We need to take time to evaluate interventricular septum, three vessel and trachea view. It's not optional, it needs to be done. And that also can be done with use of color. And I think that this is a really critical thing, as I will show you later. If you look at the international guidelines, they also were updated last year. This is the guideline from the International Society of Obstetrics and Gynecology. And here you see that the cardiac screening examination should include the assessment of the fetal situs, the four-chamber view, the outflow tracts, and three vessel and trachea view. But what's really different from the AREM guidelines, and I think that it's really critical, that the use of color Doppler ultrasonography is not considered mandatory, but to be familiar with those techniques can be really helpful for routine screening assessment, and it's encouraged. So it's very important to feel free to explore the color Doppler to improve your screening technique. So, and what is really makes the screening effective, then we do things in the systematic manner. And we can look at the examples from the different fields of life. For example, looking at how the pilots are getting ready to take off and how the entire airline industry operates. So if there is something wrong on the checklist, so that this is the consequences, and that's why this is like considered a relatively safe place, then we really have that incorporated. So, and it's really important that the last edition of the screening guidelines from ESOG provided not just the guideline itself and requires to take a look at different pictures and different views, but also provides the checklist that allows to look at those views in the systematic manner. And I'm not going to go through this very precisely today, but I would like to encourage you to download those guidelines, which are available free on the website, and look into this, because looking at things systematically and utilizing the checklist definitely improve our ability to suspect cardiac anomalies and at the end of the day refer them for fetal echocardiography. For example, if we look at this sweep that demonstrates the fetus in the bridge presentation and also shows how we sweep from the abdominal level, where we can see all the anatomical landmarks, including the stomach, the descending aorta, IVC, and the position of the portal sinus, to the four-chamber view, where we note the position of the apex of the heart, the chambers, and all the other structures, so that we can really break down this sweep into 5 critical regions and have the checklist for each of them in order to maximize the screening ability of this technique. And of course, if the patient really needs detailed assessment, if something was suspected or there are pre-existing factors putting this pregnancy in a high risk for congenital heart anomalies, there are the guidelines that are available from the AIOM or American Society of Ecocardiography that regulates what needs to be done and what protocol needs to be used. But in this presentation, I would like to focus more on the tools that we have on our ultrasound systems, because one thing that we know what we need to do, but really important to be very fluent and familiar with the options that we have in the machine to increase our ability to visualize the heart. So, and we will start from the advances in the 2D imaging. And one of them that recently was introduced on the GE ultrasound equipment, this is the Radiant 2D option. And you can see here that here we have the 4-chamber view on the both fetuses. This is the same fetus in the bridge presentation. And you can see how the application of the Radiant 2D helps with increasing the resolution, how the borders of this myocardium highlighted, and how much details we can see here comparing to this image, which is also showing a lot of details, but here we have more resolution and more contrast. That is always the goal when we are looking at the structures within the heart. So here we can see 2 examples. One is the normal 4-chamber view and the sweep towards the left ventricle outflow tract. And here we have the baby with the obvious cardiac malformation consistent with complete balanced atrioventricular septal defect. Sometimes visualization of that linear insertion of the leaflets can be very tricky, and the visualization of the septum primum ASD and the inlet PSD is difficult and the defects are relatively small, so that application of the radiant flow definitely can help the resolution and the very good delineation of those defects that make the diagnosis of the complete AV canal. So I would like to highlight another technique that is currently available on the electronic M6C Generation 3 probe, and this modality called the volume contrast imaging in 2D. So this is the excellent tool that allows the improve the contrast resolution and provides the very good picture, especially when you need to improve the contrast. So it's important to keep in mind that this is the 2D mode, and this is not the volume imaging, and that it implements different parameters and the presets that can help the visualization of the different structures of the fetus, including the heart. So here, 2 examples. One is the technique that was available a long time ago and is a part of the 3D modality. This is VCIA. And also here we can see that the fetus, the similar problem, that both of those fetuses have the rhabdomyomas. So here we have the application of the VCI2D in the tomographic preset that helps significantly improve the detection of those little malformations, so that it's pretty obvious that there is the tumor here, but we can recognize easily the mass within the septum and also attached on the chordal of the anterior leaflet of the mitral valve. So what's the difference? So both of them are VCI, so the volume contrast imaging. So the one in 2D, this is the constant high line density and exact parallel distance of the levels can only be replaced by the 2D matrix array. And also, in contrast to the 4D modification of that technique, this modality has the very high frame rate and very good resolution. So that's why this is a really revolutionary technique for improving our imaging. So here you can see the comparison between the 2D image that we can see using the high frequency probe and using the cardiac preset on the resolution. And this is the same fetus, the VCI 2D, where we can visualize the heart almost like the 3D image, even though we are scanning still in 2D and we have the same frame rate and the temporal resolution maintained. To improve the contrast, there is another trick, so we can use the tint maps, and different tint maps are available. I prefer copper, but you can use any of these 10 maps available on the system on the menu. And here you can see that assessment of the screening plane, such as the four-chamber view and the free vessel and trachea view, can be achieved on completely different visualization levels. So this is something that I would say that you should explore if you have this type of probe. So this is an example how the entire fetal echocardiogram can be performed using this technique, and this is the best for cardiac imaging. So, but this is also can be applied in the inversion mode. And here is the fetus at 25 weeks, at 35 weeks, the complete AVST. And you can clearly visualize that using the inversion mode. And sometimes those images can be also helpful for diagnosis. So, but I would like to demonstrate this not on the patient that really scans beautifully. It's probably any technique would be okay to make the diagnosis. I would like to bring us back to the challenges in OB practice. And here is an example of the patient that presented at 17 weeks and 5 days, that the history of the prior child born with the major congenital heart anomaly. So she was extremely anxious and very high BMI. And of course, she wanted the reassurance. She wanted to make sure that this fetus, new baby, doesn't have the cardiac anomaly. So I think that looking at this four-chamber view, it's very difficult to tell or be confident if this four-chamber view is normal. In order to improve the visualization, we switched to electronic probes and applied that BCI 2D using contrast. And you can see how dramatically the contrast was improved in this case, allowing the visualization of the four chambers and application of the tint map because our eye can see much better in shades of color than in the shades of gray, can help us to reassure that this is a normal four-chamber view and the fetus doesn't have any major cardiac anomalies. So another example, again, the patient with a high BMI, the very poorly controlled pregestational diabetes. Those patients are always at risk for congenital cardiac anomalies. Then the A1C is over 10. Here you can see you basically challenged the same question. Can we call this heart normal or this is abnormal heart? Looking at this four-chamber view, and to be exact, the axial plane of the fetal chest at the level of the four-chamber view, we can visualize that the heart is beating, but we cannot see much detail. So that you can see that how dramatically the situation will change when we apply the VCI 2D in the contrast setting. We can visualize that the axis of this four-chamber view, the cardiac axis, is deviated significantly left. We can see four chambers present, but looking at the outflow tracts, we can clearly visualize that there is one vessel that overrides the septum and originates more from the right ventricle, and that was the case. So I think that here I can convince you that this is a really good technology for making the diagnosis on the difficult patients, but sometimes difficulty is different. So this is the patient who presented for fetal echocardiogram at 24 weeks gestation, the family history of the Schwann complex. And on the previous baby, everything started from bicuspid aortic valve, and that it developed to the critical aortic stenosis. And unfortunately, the newborn passed away. So in this pregnancy, they presented very anxious and were wondering if this baby has the bicuspid aortic valve too. So can you tell looking at this picture? Maybe, but what's the confidence of that? And using the, again, the VCI 2D, we were able to visualize that valve very clearly. And this is, you can see that 2 leaflets of the aortic valve. And that is really looks very easy on this ultrasound to recognize that indeed this is bicuspid valve. But at this point, there is out any evidence of stenosis or insufficiency. So this minor details also can be picked using this technique. So we are moving to the advances in the color Doppler imaging. So here we have 2 eras. So this fetus had the Epstein anomaly, and this fetus has Epstein anomaly. Both of them were scanned in our department few years apart, and you can see how nice and 3D looking this color is. And this is because the radiant flow technique that was recently developed. So also I would like to highlight that ultrasound equipment on GE has a wide range of the color Doppler modalities, from just conventional color Doppler and HD color Doppler to slow flow, which is the technique for the microvasculature assessment. And I would like to spend more time on that. So all of those color Doppler modalities can be used, the radiant flow or 3D appearance of 2D image, or in the volume imaging. So this is the example how the radiant flow can help to visualize the blood flow in the fetal heart as early as 15 weeks gestation using the regular convex probe. You can see how the that 3D effect helps to navigate where the interventricular septum is and separate 2 inflow channels. We can also look not just on the intracardiac flow, but evaluate the HD modality, HD color, for assessment of the smaller vessels such as the pulmonary veins. And slow flow technique, this is the microvasculature modality that present the unique technology for 2D and 3D visualization of the microvasculature. It's very easy to apply in early gestation for detailed assessment of the cardiac structures and any vascular structures within the brain or anywhere in the fetal body. It's a helpful tool for cardiac assessment, in particular for the pulmonary veins, the vasculature within the liver, and the aortic arch malformations. And I will show you a few examples. So looking at the presets for the slow flow HD, first of all, you can choose from the different maps. There are 8 maps here. And even though I have to urge you that the direction of the blood flow that can be presented on the directional maps not always represents the actual flow direction, because the velocities are so slow. And the main advantage of this technique is indeed just to visualize flow, not really to detect the direction. But you can use the knowing those limitations, you can use between the directional maps and the not directional. And based on my experience, the number 4 and 8 usually helps to visualize things very nicely for me. So we can apply this technique for the better visualization of the hearts in the first trimester. Now we have the separate guideline for that. And here is an example where we can look at the 4-chamber view of the heart. We can visualize the pulmonary veins, interventricular septum, and the free vessel and trachea view. And that early, and this is 12 weeks gestation, we can rule out the wide range of the congenital cardiac malformations. We can look a little bit later. This is 14 weeks. Again, very good delineation of the 4-chamber view, that all anatomical landmarks that need to be looked at that stage. And of course, in the third and second trimester, the evaluation of the pulmonary veins and the entire vasculature of the lungs can be easily achieved using this technique. So how about the abnormalities? So the total anomalies pulmonary venous return is traditionally very difficult diagnosis to make prenatally. And here we can clearly see that typical big sign for the total anomalies pulmonary venous return in situation where we have also major cardiac anomaly in settings of the heterodoxy syndrome. We can take a look at the aortic arch. Diagnosis of the aortic coarctation is very challenging task. And here we have the normal aortic arch, the very nice head and neck vessels visualized, and you can see how much the color stays within the vessel and there is no bleeding artifact, the very good delineation of the head and neck vessels here. And this is the case of the aortic coarctation. We can see how the isthmus is elongated. We can clearly visualize the origin of the left subclavian artery and how much it displays downstream from the origin of the carotids. So all this can be achieved applying this slow flow Doppler technique. Then we perform the cardiac evaluation. The minor vascular anomalies, such as the aberrant right subclavian, this is the fetus 16 weeks gestation, also can be visualized pretty easily. And any malformations that include the anomalies of the aortic arch can definitely be diagnosed, and the diagnosis can be done easy if we apply the slow flow HD. This is the example of the vascular ring, which is formed by the left-sided ductus arteriosus, right-sided aortic arch, and we can clearly see on this clip the origin of the right subclavian artery and the aberrant right subclavian artery, which makes this case the vascular ring. This is another example of the vascular ring where we can see the double aortic arch. We have the left-sided ductus arteriosus, the left side hypoplastic, and the right sided aortic arch, making the complete encirclement of the trachea and esophagus. So this is a very unique case of the vascular ring that demonstrates the left-sided arch that runs here on the left from the trachea, but the right-sided ductus arteriosus, which are connected behind the trachea and esophagus, and again represent the very rare form of the vascular ring. We can look at the different major cardiac anomalies. This is relatively early, 16 weeks gestation. The fetus has very complex malformation that consistent with the heterodoxy syndrome, left isomerism. We can visualize the common inlet. So the common EV valve here, the common atrium that has the very symmetric atrial appendages of the left morphology. What's really remarkable here, this fetus also has the abnormality of the development of the myocardium, the channels that you can see here. And this is the myocardial node compaction that makes this prognosis really, really poor, because usually those fetuses develop hydrops and unfortunately result in the demise at some point within second or third trimester. This is the same fetus. So the slow flow technique allows us to visualize the great vessels. We can see how small the pulmonary artery is. It's a pulmonary atresia. We can see the bilateral SVCs, and we can see also, if we slow down this video clip and retrieve the frames, individual frames, we will be able to make the diagnosis using just 2 sweeps. The one that we saw in the previous slide, and here where we have the superior vena cava, azygous and hemiazygous veins draining their pulmonary atresia dilated aorta. So this is probably the most important things about the color, but if we look at the more detailed assessment of the heart already in the settings of the fetal echocardiography, I would like to highlight 2 very important things that now required as the part of the fetal echocardiogram. This is the cardiac biometry and the pulse Doppler ultrasonography. So, and what is really remarkable about the options that we have on the machine, this is the flow profiles. And I would like to highlight this for you because I think this is a great achievement that allows very quick optimization of the Doppler modalities, including color and the spectral Doppler. And I would like to show you how that can be implemented. So every time then we apply spectral Doppler, color Doppler modality, we need to make sure that we adjust and do the optimization of the following parameters and controls. This is scale or PRF. This is the wall filter, the sweep speed, gain, and the baseline. So that the flow profiles techniques, this is the adjustment that can be done based on the vessel that we are looking at by pushing of the one button. So all these adjustments of those multiple controls occur on the back end, and the only thing that you need to do, you just need to make sure that you have the appropriate angle of inclination and that you know which vessel you're going to examine. So this is how you can optimize the trace like this in the umbilical artery, and you push just one button and the trace is adjusted. So you don't really have to spend time on that. And it gets even better because the automatic measurement or the automatic trace can be applied and help with overall the quantitative assessment of that curve. So if we are looking at the fetal echocardiogram, we are required now to obtain the spectral Doppler curves across the tricuspid and mitral valve. And usually those spectrums, they look biphasic. This peak represents the early diastolic or passive filling of the ventricles during early diastole. And then the A wave represents the atrial contraction. And this is what you usually can see looking at the tricuspid or the mitral valve trace. What we are really looking at and what is considered pathologic, then the filling of the ventricles is very short, and that we can see only one phase, like it's also called the monophasic filling. And of course, the most of the systole, we can see the significant backflow across the valve that's called the tricuspid or mitral regurgitation. And this is the typical changes that we usually see on the spectral Doppler. Monophasic waveform is typical for the aortic or the pulmonary valve assessment. And here we're also looking for the evidence of the increased velocity of stenosis or presence of the significant insufficiency that usually occur at the time when the valve was closed, so in diastole. So very often then we perform the cardiac assessment within the settings of the fetal echocardiogram. We need to switch between the different settings. And again, depending on what we are looking at, the intracardiac valves or the arteries or the pulmonary veins and the veins within the liver. So we need completely different presets in completely opposite settings for the velocity scale, wall filter gain, and the persistence. So this is where the flow profiles play the critical role, because you can go back and forth from the cardiac flow to the pulmonary veins flow in just pushing one button. And you can see that this is the cardiac flow preset, so you cannot really see the pulmonary veins very well. And this is how nicely the pulmonary veins will be delineated if you go to the pulmonary veins preset. The same thing is true for the assessment using the spectral Doppler, and you can go from trace like this to this very nice and optimized trace by one button. So here is the typical flow and the typical assessment of the inferior, right, and left pulmonary veins. And you can see here that we can assess not just the flow in the veins, but also the flow in the arteries, and that can be utilized for assessment of the baby's flow arrhythmia. So, but if you look at this example, so we have the 2D image and the color Doppler. This is the screening exam. Can we tell for sure if it's normal or abnormal? And this is where the role of the spectral Doppler is, because here this fetus presented for echocardiogram, so we followed the guideline and we assessed the pulmonary veins not just in color but using the spectral Doppler. In this non-pulsatile blood flow and monophasic feeling of the blood flow that we can see here in the pulmonary veins is very specific and very diagnostic for total anomalies pulmonary venous return. So this fetus, the next step, we need to figure it out where those veins are draining. So the clinical value of the Doppler, if we summarize all of this, is here, so that we look at the blood flow across the AV valve for stenosis, atresia, and insufficiency. We look at the blood flow across the semilunar valves, looking for stenosis, atresia, agenesis, or insufficiency. We're looking at the blood flow in the great vessels. We're assessing the interventricular septum. We pay special attention to the blood flow across the ductus arteriosus, ductus venosus, and the foramina valley. So assessment of the fetal shunts are really a very important part of the fetal echocardiogram. And of course, we are looking at the normal drainage of the systemic and the pulmonary veins. The next important part of the fetal echocardiogram and relatively new, which is required, this is the performance of the measurements. And here you can see the general considerations. And as usual, the assessment and visualization starts from the optimization of the 2D, and in particular, the appropriate magnification. So we measure diameters of the valves and vessels at the moment of the maximum expansion. That means that we are measuring mitral and tricuspid valve in diastole, and the aortic and the pulmonary valve in systole. So the vascular diameter should be perpendicular to the long axis of the vessels. We perform inner edge measurements for the vessels and the valves, and also the leading edge to leading edge if we measure the myocardial thickness. So on the package for the cardiac measurements, we have very sophisticated parameters that can be evaluated. Basically, in the heart, you can measure lots of things, but I would like to highlight the most commonly used. One of them is the cardiothoracic area ratio, and you can see here that we can look at the area ratio and circumference ratio and the normal values presented here, and it's important to use the appropriate normal value then you interpret the results. Then we look at the measurement of the tricuspid and mitral annulus. You need to magnify your image first, and then you need to reassure that the valves are open. And here you can see that this is how the four-chamber view should be presented: apical or basal orientation, sufficient magnification, heart is in diastole, so AV valves are open, and absolute values of the measurement should be similar. And this is how you can use the package of the machine to achieve these measurements. So the aortic valve diameter, again, we are looking at the LVOT view, and here we need to make sure that the valve is completely open, and the normal valve will demonstrate no leaflets in systole, so they will be not visible. This is exactly where we're supposed to apply the measurement. Here we need to get the LVOT and sufficient magnification and clear visualization of the aortic root. We need to find the frame that shows the aortic valve completely open. It's in systole, and the measurement should be perpendicular to the long axis of the vessel. Also, we are looking at the same fashion for the pulmonary valve, and here we have similar checklist to ensure that the measurement, that the view is appropriate and the measurement applied appropriately as well. So all the measurements that we perform during the fetal echocardiogram, if you measured the baby before and if the system knows the gestational age during the exam, can be presented as the z-scores. So the concept of the z-score is presented here. So basically, this parameter tells us how different the measurement that we just obtained for this gestational age or the fetal biometry, such as the BPD and the femur length, and if this is within this two standard deviation for those parameters. In other words, the interpretation of the z-score is that it's normal, then the value is in between -2 and 2, and the average is 0. So less than -2, and in particular less than -3, that means that the structure is small and that the hypoplasia should be considered. And finally, if this is over 2, so that should be considered as dilation or very big structure. So this is really easy to interpret, and you can do that on the fly just by looking at these numbers. Then you receive this from the package. So the clinical value of the fetal cardiac measurements, this is the objective interpretation of the abnormal findings, differential diagnosis of the cardiac anomalies, allow us to assess the dynamic changes and growth through gestation, contribute to evaluation in the rare occasions that we consider the fetal cardiac interventions, and also we can help doing the measurements that can help the estimation of the prognosis and the course after birth. A few words about the volume imaging. I think that this is the new probe. We have really advanced the resolution and the temporal resolution in particular. Then we do the volume imaging. We can reconstruct in the rendering mode the normal hearts and the abnormal. That is the communication to the subspecialists, in particular cardiac surgeons and cardiologists. We can locate the anomalies such as the VSD very precisely, what segment of the septum is affected, and we can retrieve the longitudinal views and the cross-section views as well. And of course, then we are looking at the vascular structures, in particular in the superior mediastinum or in the abdomen. So this is the very useful technique to reconstruct those vessels and find out the spatial relationship between them. So also, everybody is really into the artificial intelligence, and I would like to highlight that the ultrasound systems from GE Healthcare, they have a lot of artificial intelligence algorithms, but I just want to show here that one of the oldest one was proposed almost 20 years ago by Dr. Abu Hamid, and this is the concept of the automated multiplanar imaging, and it's still available on the machine. And this is how you do the acquisition, like any volume of the baby's heart, and then the ultrasound system is smart enough to recognize the four-chamber view, place that in the appropriate position, and then you have the whole package that's called the SonarVCAT that can help you to retrieve the diagnostic images, such as the four-chamber view, the left ventricle outflow tract view, the right ventricle outflow tract view, the situs view, and the sagittal plane, such as the bicaval plane, ductal arch plane, and the aortic arch plane automatically from the volume that you acquired. So keep in mind that this can be very helpful tool, not just for diagnosis, but also for review your cases and for teaching. And I would like to stop here, and everybody who is interested in the fetal cardiology, please welcome to apply for our fellowship at EVMS, and I'm happy to take any questions. Thank you very much.